It's a great honor to host this webinar tonight. The topic is highly relevant and sometimes controversial, but we believe it represents a valuable opportunity for us as therapists to improve the quality of our interventions, while also supporting both the surgeon and the patient. This evening, we are privileged to have with us two leading experts on the subject. We will begin with Mr. Donald Lalonde. Donald Lalonde is a Canadian surgeon internationally recognized for his pioneering work in wide-awake hand surgery. He has authored numerous publications and has been instrumental in promoting safer, more efficient, and patient-centered surgical approaches. In addition to his surgical expertise, Donald Lalonde is also at the forefront of integrating ultrasound into clinical practice, particularly in advancing ultrasound-guided hand therapy and interventions. As an educator and thought leader, he continues to shape the future of hand therapy and rehabilitation worldwide. Following him, we will hear from Nuria Carnicero. Nurìa is a Spanish physiotherapist specialized in climbing-related injuries and rehabilitation. With a strong background in sports physiotherapy, she combines her clinical expertise with a deep knowledge of climbing biomechanics and performance. She is highly experienced in ultrasound-guided hand therapy, which allows her to provide precise and effective rehabilitation strategies. Nurìa has become a reference point for climbers seeking injury prevention and recovery, blending advanced therapeutic methods with her passion for movement and sport-specific training. Now, we are pleased to give the floor to our speakers, starting with Dr. Lalonde. We kindly ask everyone to remain respectful and keep microphones muted throughout the session. Please note that any disruption may lead to removal from the webinar. All questions will be collected and addressed at the end during a dedicated Q&A space. Please, Dr. Lalonde.
Good evening. I hope everybody is doing as well as I am. I feel terrific. It's a beautiful late summer day here in Canada. And it's an honor and a privilege to speak to some of my favorite people who are hand therapists this evening. I think that we're all used to x-rays and mini C-arms where you just put a patient's hand underneath the x-ray beam and you can see bones. Well, I think that the surgeon and the therapist of the future are all going to have an ultrasound probe. This was my first one. It was a butterfly hooked up to my iPhone. It was a wired one. This is my current one. It's a Clarius wireless ultrasound. And, they're getting cheaper and cheaper. And I think that in time, we're all going to have one. And everybody's just going to go to it all the time. It's very helpful to see things like wood. Mario, can you see the little hand in the screen?
Yes, it works.
Perfect. That's great. So this little piece of wood is this little piece of wood. It's a sliver. You can't see that on X-ray, but you can see it on ultrasound. And you know that it's solid because it's white. Things that are black are liquid. So you see black around the solid piece of white. That black around the solid piece of white is pus. And so it's very helpful to see things. But in some ways, it's a little hard to see because you have to think of an ultrasound slice like the slice of a CT scan. You're only seeing the width of a credit card. That's what you're seeing when you look with ultrasound. And that's why you can't hold an ultrasound probe very, very still. You have to keep it moving if you want to find things. And in the beginning, it's hard to figure out what you're looking at. So you always start by finding the bone because bone is solid. So it's white and it's on the bottom. And ultrasound waves don't go through it, so you can't see past it. It's not like an X-ray. The ultrasound waves bounce off the bone, so that's the stop sign. So always look at the bottom and you're going to see the bone. And then you get patients to move, ask them to move their tendons, and you'll see the tendons move. Now you see the tendons and the bones, and then you just figure everything else out because it's pretty easy. You can figure out the nerves, you can figure out the blood vessels. And so you're moving the probe proximal to distal, you're moving it radial to ulnar, you're tilting it up and down. And I'm going to talk about tilting in a little while because that's very helpful. And then you rotate the probe around so that you can see things. So this is a dynamic thing. It's not a static thing. Static is a ultrasound image. So this is an ultrasound image from a paper. And you look at that and your eyes glaze over. Mine do. I can't see a damn thing. Sure, you're telling me that's the recurrent branch of the median nerve. I believe you, I guess, but I can't see it. Why can't I see it? Because it's not moving. And so I don't have a context. I recognize that nerves are like spaghetti. They've got these black lines and white lines and they're striped. I get that. That kind of looks like a nerve. But if I am holding the probe and I'm moving it back and forth, the nerve becomes a lot easier to see. So don't be discouraged by still images in ultrasound. They're useless. You need to keep the probe moving. And so that's why you need to do it yourself. So this is the de Quervain's canal. This is the first extensor compartment. And this is a video by Gonzalo Belmar from Chile. And there's extensor pollicis brevis and abductor pollicis longus. And it still doesn't look very good until you get the patient to move. And then you can see the two compartments in the first compartment, where extensor pollicis longus is separate from abductor pollicis longus. And the best place to start is on your own hand. And this is a transverse view. That was a longitudinal view. Here's the transverse view. And you see how the tendons split at the septum. The septum is black in between. There's the septum between the abductor pollicis longus and extensor pollicis brevis. As you look at your probe on your own hand, it's very easy to figure these things out. So you just get a probe, you take it home, look at your own hand, and you figure out your anatomy. Now, I'm going to show you this video. This is from a paper that we did called Teach Yourself Ultrasound. And if you just take a picture of the QR code, it'll take you right to the paper with these free videos, including this one.
The bottom left shows an annotated view with important anatomical structures, and the top left is the unaltered ultrasound image. Here we see the FTP tendon insertion into the distal phalanx. The volar plate is also visible, crossing from the middle phalanx to the distal phalanx.
See, there's the bone at the bottom. There's the tendon on top of the bone. And this thing right here, see, that's a joint. You can figure that out, right? There's the metacarpal and the proximal phalanx. And there's, this is the middle phalanx and the distal phalanx. And there's profundus right there, the profundus tendon, and there's the volar plate. And you can...
It's also visible, crossing from the middle phalanx to the distal phalanx.
So now you're over the middle phalanx, and you get the patient to flex the fingertip up and down, and then you can see the tendons move. Because when the
tendon can be seen gliding as the digit is actively flexed.
So there's the tendon right there.
As we pass the PIP joint, the two slips of the FDS tendon come into view as they move towards the midline of the digit at Camper's chiasm. The FDP tendon is now passing underneath the FDS. Isolating the FDP and FDS shows the movement of each of these tendons independently.
There's your two tendons there. That's profundus, and there's superficialis. And so
here we see an axial view of the digit.
That's what the joint looks like. Right there, that's the joint.
The annular pulleys and flexor tendon sheath are easily visualized. The insertion of the FDS tendon is clearly seen as it starts deep to the FDP tendon and then quickly becomes superficial at Camper's chiasm.
So you can look at these videos on your own time, and you can look at your own hand, and you can figure all this stuff out. You don't need to go to a course to learn ultrasound. You just need an ultrasound probe in your own hand because you know your anatomy. So this is the paper that comes from, and it's how to teach yourself flexor tendon injuries and how to manage them as a therapist or a surgeon. So here's a patient who's got 2 lacerated flexor tendons in her 4th and 5th finger. So that's pre-op, and that's 12 weeks post-op. And one of the things I did was after I injected the local anesthesia, I ultrasounded her so I could see exactly where the ends of the tendon were. So here I am. What you're going to see is you're going to see the bone of the middle phalanx. You're going to see the DIP joint. And then on top of the bone, you're supposed to see a solid white tendon, but you don't. You see an empty black sheath, but you're going to see the FDP distal stump of the ring finger. So I'm going to show that to you now. So I'm passively flexing the DIP, and you can see the little stump of profundus there. And then you see the bone of the middle phalanx. And here's the black tunnel where FDP is supposed to be. Now there's FDP right there at the PIP joint. There's the distal end of FDP. FDS is still intact. And there's the volar plate on top of the joint. This thing here is the volar plate. Don't let it fool you. And you just get the patient to flex. And here I am asking her to flex. And so you can see superficialis right there is moving when she flexes. And so it's all about, you know, your anatomy, you get the patient to move, and you figure out what is where. You don't need anybody to explain it to you. You figure it out. So this is where it's very helpful as a therapist. And this is one of the things that I would show people is this is how you can help patients. So once again, here's the bone, right? And this just looks like a blob. And that blob is there because this is a repaired flexor tendon. It doesn't look clean. It looks full of scar. And there's something very solid in there that is normally not there. And that's a piece of fiber wire because this is a suture inside my intact tendon. And it's easy to see that my tendon is intact. See, look at the suture move, look at the tendon move, but it's not clean because there's a lot of scar around it. It's stuck in scar. And, you know, the therapist came to get me and said, gee, I don't know if this tendon is moving or not. Well, we ultrasounded it. Clearly, it's moving. Now what we do is we have the patient look at it. So this is the patient looking at his own tendon move with ultrasound. And, you know, he came in going, I don't think it's moving. Oh, yeah, I can show you that it is moving. Watch. And so this is like G feedback. This is auto visual feedback. They're seeing their own tendon move. And we do this a lot in our clinic. So he's moving his tendon, he sees it move, he's getting auto feedback, and he's going, okay, it is moving, and that's how you move it. So here's another case. So here's a case where I repaired profundus in this man in our procedure room. And there he is. Here he is at 4 days after surgery, and we start up to half a fist of true active movement, like probably most of you are doing. I know some of you still do place and hold, but we like true active movement. And here we are at 2 weeks, and we let them do these simple, non-forceful exercises. They can move it, but they can't use it. So this isn't using it. This is just moving it. And this forces them to move profundus. And look at the profundus of the long finger. It's beautiful, right? That's at 2 weeks. But then at 4 weeks, he got stuck and he wasn't able to move at all. And so we looked at him with ultrasound in the clinic, and we saw that the tendon was intact. So what we did was we put him in a relative motion extension splint. And this is 1 week after being in the relative motion extension splint. He was stuck 1 week ago, but just putting him in this splint has helped him start to flex. And so now he's exercising while he's living. If you're stuck after a flexor tendon repair, relative motion extension splints are great because people don't have to stop living to exercise. They exercise while they're living. And here he is 4 weeks after the relative motion extension splint and 2 years after surgery with full flexion.
Relative motion.
So this is another patient that I'm going to show you his whole course. So this is a tough case, right? Because it's superficialis and profundus that are cut. And here he is toward the end of his therapy. And then I'll take you right to the beginning when he cut himself. So here we put him in a relative motion flexion splint because he had an extensor lag. And this was at the very end. And you see how little PIP extension he has? He's got a big lag there. But here he is starting with a relative motion extension splint. And as 2 weeks later, he gained 20 degrees of extension in this relative motion extension splint. And so that's how we got extension later, was with a relative motion extension splint. And here he is at 6 months after the repair, and he got excellent movement. But this is where we started in the very beginning. And these are hard because this is a fifth finger in a short, fat finger. These are difficult. And so here he is the day of the surgery. And this was an old case because I have a long incision. Today, I would just have a short incision. So there's after the repair. This is with true active movement. You can see that there's a little bit of bowstringing there, but it's not enough to be clinically significant. And so we've divided A4, and A2 is completely intact. And when we pretend to do place and hold, the tendon doesn't glide when we passively flex it. But when we actively flex it, it jerks into place. So this is true active movement. You get nice gliding. And with place and hold, you get buckle and jerk. And here he is at the end saying, I can move it, but I can't use it. And then we started at 3 to 5 days with passive flexion first. In these days, we were still using a long splint in the beginning. Now we use a Manchester short splint right away. But here he is at 12 days with true active movement. So he's gliding. And then we moved him to a Manchester short splint at 1 to 2 weeks. Again, today we would do that right after surgery. And this is Amanda, our hand therapist. And here we are doing these scrunching the Kleenex movements or flipping your cell phone movements. This is moving it, but not using it. And all this is designed to help profundus. So then it looked like he was stuck. There's the tendon stuck in scar. And so we put him in a relative motion extension splint to help profundus get out of scar. And there he is moving his own finger and watching his tendon glide on the screen. And finally, we see he still doesn't have great flexion of his profundus. It's still pretty stuck. He's got pretty good extension at this point, but his profundus is stuck in scar. So Eventually, we ended up where we saw him before with extensor leg, and here he is at 6 months. So you have to keep working with these. You know, the therapist and I look at what's going on with ultrasound, and we decide what to do. So 3.5 months ago, we cut the thumb FPL through a little poke hole right there with a knife, but no nerve injury. And go ahead and try to bend your thumb as best you can. So that's not going to work very well. And we ultrasounded it. Right there is the center of my probe. And that's where the stump is, right there. And the distal end is zone 1. It's way out on the tuft. So this is the distal end. This is the distal phalanx. There's the proximal phalanx of the thumb. There's the distal tendon. There's the volar plate here again. Here's the tendon right there at the level of the mid-metacarpal, just as advertised in the ultrasound. So when we go back here, I'm just going to go back and forth. Of my probe. Right here is the stump of the tendon, and it's kind of balled up on itself. There's FPL, but I'm getting the patient to actively flex. And as the patient actively flexes, that little stump moves back and forth. So I know that's the stump of the tendon in between the two muscle bellies. So I'm able to make shorter incisions, and short incisions are good. You don't want long incisions. And so you should encourage your surgeons to use ultrasound so that they can make short incisions. The shorter the incision, the less scarring. The less scarring, the less tenolysis. So patients come in with 2 hands. Always look at the normal hand first, then look at the problem hand with ultrasound. It's one way to teach yourself ultrasound. So if somebody comes in and they've got a long finger problem, don't start with that finger. Start with their normal long finger, so you know what a normal one looks like. And then look at the one with the problem, and you can figure out what the problem is. Here's another film by Gonzalo Belmar from Chile, looking at the ulnar collateral ligament, which is this black thing. And you always look for the adductor tubercle. It's the big bump here. And that's where the ulnar collateral ligament starts. And in this view, right here, there's the adductor tubercle. The ulnar collateral ligament is not out straight and stretched. It's scrunched up like an accordion because it's ripped. There's a space in the ligament, but the adductor aponeurosis is still intact. So this is not a Stenner lesion. The ligament is inside the joint. So this is just going to heal with a cast. I don't need to operate on this. Even if, I can stretch it out. So that's what you're looking at right there. And eventually you figure out what these things look like by looking at them yourself. And by keeping your probe moving, you can see everything. So this is what an ulnar collateral ligament tear looks like. The ligament is outside the joint. And now you can take that tendon and bring it right over, or the thumb and bring it right over. And there it is. There's the ligament outside the adductor aponeurosis. The adductor aponeurosis, you can see it move as you get the patient to flex up and down. Again, this is a moving sport. You want to see the movie. So there's the torn adductor aponeurosis. There's the ligament outside the joint. And these things become easy to see the more you look at them. This is a case that I did myself. There's the ligament outside the adductor aponeurosis, which is blue. And again, it doesn't mean anything unless it's moving. So now you can see the ligament a little better. You can see the adductor. And it's moving. Sometimes patients come in and they're very, very sore, and they don't want you to put the ultrasound probe on their hand. So what you do is you submerge the ultrasound probe in water. So you put gel inside a glove, And then you don't touch them with the probe. You let water between you and the glove. The water actually magnifies things and lets you see things more easily. So you can get patients to do exercises in water, and you're not pressing on the skin that's sore with a probe, and the water magnifies the signal. You can see better underwater. You can't put a probe underwater unless you buy a $1 million probe, but you can put any probe in a glove with gel. So still photos are worth 1,000 words. Movies are worth 1,000 photos. Your ultrasound exam should be a movie, not a photo. So you keep moving your probe until you get an important view, and then just pause. Just pause, and then go back and forth over it and get the patient to move back and forth, and you will see things. I'm just going to pause there for a moment because I would like to show this video from Tom Latre, who's very, very clever. Now, can you guys see that video, Mario?
Yes.
Perfect. So the median nerve is right there. And I'm just going to pause that for a second. The nerves look different than tendons. Nerves have these black stripes like spaghetti in them. Tendons don't. They're solid white. And so here he is flicking his screen on his phone, and his FPL is solid white, but the median nerve is not. But I just want you to watch the median nerve move. Nerves move. And as a therapist, you can actually watch your nerve move, see how much it moves. I mean, you do gliding exercises, you do nerve gliding exercises. Wouldn't you like to see what makes the nerve move the most? And Tom, I know you're on. Thank you so much for allowing me to show this video. Anybody can get it on LinkedIn, but this is a very clever idea, because when you're doing nerve mobilization exercises, you can actually see if the nerve is moving or not by doing your own ultrasound. Right, so I'm going to come out of there and I'm going to go back to my PowerPoint presentation. Now, one thing that's very helpful when you're doing ultrasound is to have a mountain of gel. Not a thin layer. I'll show you why in a minute, but you see, there's the skin, there's the ganglion cyst. It's black because it's got liquid in it, but there's the gel between the skin and the probe. The probe is there, there's a layer of gel, and there's the skin. If you have a thick layer of gel, you don't get artifacts, and you get magnification of this structures underneath. So one of the keys to getting a good image is to have a mountain of gel, a thick layer. Look at how thick that layer is. The whiter my hair is, the thicker the layer of gel. Because if you have a thin, see, I'm going to put a needle into the ganglion through that thick layer of gel. So there's the needle coming in right there. You see the point of the needle right there. Now I know I'm inside the ganglion, and I just go ahead and aspirate it. This you're going to see. If you have a needle, this here is like a shadow underneath the needle. And you only get glimpses of the needle, and you only see the needle when you're parallel to it. It's like a credit card. You have to have your credit card lined up with the needle in order to see it. So that's how I use it for that. Wait, let's just go back. There we go. So this is a flexor sheath ganglion. And once again, here's the joint. There's the MP joint. There's the tendon right there. And there's the ganglion, the black hole. So you can cut out flexor sheath ganglions, or you can put a needle in them and explode them with local anesthesia. And if you do that, they don't even need surgery. And that's what I did for my friend. I put a needle inside her flexor sheath ganglion. I injected lidocaine with epinephrine. There's the needle right there. I exploded the flexor sheath ganglion, it went away, and it didn't come back. So you can do that instead of surgery as a surgeon. So here's a mass. There's a thick, thick layer of gel. And I don't know if this is solid or liquid. So I'm looking at it. Yeah, that's liquid because it's black. And it turns out that this is a ganglion. So that's pretty easy. But sometimes it's not so easy. So what's this thing? Here, let's just go back to that for a sec. What's this thing? This is what it looked like when I took it out. And there's blood vessels going to it. There's the blood vessels going to it. But this isn't water filled. There's the other blood vessel. And here's what it looked like before I took it out. It's gray. You see how this isn't white? So this is a tumor. It's a growth. Sorry, it wasn't black. Black is liquid, white is solid. This is gray. So this is some kind of a tumor. And I didn't know what kind it was. So one thing that's helpful is to put on the color Doppler. And if you see an artery going into it, there's the color Doppler. Ah, maybe this is a glomus tumor. There's the digital artery right there, and there was an artery going to that glomus tumor, and that's what it was. This is a benign tumor. It's a benign angioleiomyoma. I only knew that when I took it out. I didn't know what it was before I took it out, but I could see it. I could see it was gray. So I knew it was some kind of growth. It looked very well circumscribed, so probably not a cancer. And here it is when I took it out with Lalonde, of course. So here's a darker lesion. When you press on this, it hurts. When you put ultrasound on it, it lights up. And this is a traumatic vascular malformation. You smack your finger, you hit your finger, an artery heals to a vein, and then you get the vein that slowly expands and the capillaries slowly expand. And this is what it looks like. So this is a traumatic vascular malformation. And so I need to find the artery. I need to find the artery that's feeding this, the little arterial branch, not the whole digital artery. I don't want to make the finger cold, but there's the little arterial branch right there that I saw with ultrasound. So I know exactly what I need to do. I need to cut that little thing, and I'm going to solve this problem. If you're doing a Dupuytren's, one of the hard things, if you're a surgeon, is when there's a spiral cord, because the artery, see the artery is going up there? It's going up and around the cord. So you know there's a nerve with that artery. So I know even before I cut it open that there's a spiral cord. So I'm going to be much more careful when I take it out. So one thing when you're seeing patients who have pain, just press with your probe. Pretend it's your finger. Find the place that hurts the most by gently pressing with your probe. And the patient's going to go, oh yeah, right there it hurts the most. No, back here, not so much. When you press with the probe right there, that's where it hurts the most. So that's where the pathology is. So you look where the pathology is by using your finger, your probe like a finger. If you press with the probe and it hurts, that's the place where the pain is. And so the ultrasound probe is like an extra finger, but it lets you see through the skin at what you're looking at. This is pus. And you look at that and you go, there's no way that's pus, because it's a still image. But if you press on the skin, it becomes a movie. Now you see the pus going back and forth when you press on the skin. And you go, okay, there's liquid there above the fascia. There's not supposed to be liquid there. That's pus. And that's where the end of the pus pocket stops, right there. So that's where I'm going to stop my incision. So if you're looking at a finger, you can see pus as a therapist. And you can say to the surgeon, I got a patient here. I think I'm seeing pus there. I mean, it's a lot quicker than sending him to a radiologist. The surgeon can come in and look at it himself and go, yep, that's pus, you know, I need to drain this. And also, this is a lipoma up here. This is the trapezius muscle down there. Lipomas don't move, but muscles move. So I can tell if a lipoma is underneath the skin or underneath the muscle or over the muscle. This is where it was on the shoulder, and this is what the lipoma looked like when I took it out. So I knew that this lipoma was on top of the trapezius muscle and not under it before the surgery. So again, that's very helpful as a surgeon. So to be a surgeon or a therapist without ultrasound is like looking after patients blind. You want that extra eye. Now, here I just want you to see the thick layer of gel. This is really important. And if you look at this, here, just a sec. Okay, there's the ganglion moving back and forth on the left. You see that? Okay. Now we're going to put the ultrasound probe on it. On the left, there's no thick layer of gel. On the right, there's a thick layer of gel. Look at how much better you can see the ultrasound or the ganglion moving back and forth with a thick layer of gel. And over here, I'm going to show you something. When you look with ultrasound, you sometimes get this, where you don't see anything over here and you don't see anything over here. Do you know why? Because there's air between the probe and the skin. When you have a thick layer of gel, you never get these black hole artifacts. So artifacts can be black holes. You see this artifact right here? That's because there's air between the probe and the gel. And here's another artifact right here on this side. And on this, you never get an artifact because there's never air between the probe, which is this line, and the skin, which is this line. So you always want a mountain of gel so you can see better. And you can make your own mountain of gel. You can take, this is just cardboard with a sticky piece on it. Occupational therapists can make your own probe booster. So what you're doing is you're making a little cupcake. You're fixing it so that you have a mountain of gel on your probe. And so you see how he's creating, this is Vincent Martinel from France. He's creating a little bit of a bowl to put his ultrasound in, and you get very thick ultrasound, and it's like mayonnaise. It sticks to itself. You see how he's got a little mountain of gel there? Well, you could make one of these with any of your materials, that you're splinting materials, and now you have a mountain of gel. So here is Vincent Martinel without a mountain of gel on the left, with a mountain of gel on the right. And that little cupcake he calls a booster. And look at how much better you can see the same finger. You see all the artifacts on the left? Let me show you those artifacts again. Right there. You see all that on the left? That's artifact. Artifact is where there's air between the probe and the gel. When you see that, you need to put more gel. And when you see more gel, then you can see everything you need to see. So this is my own finger. Let's go back there for a sec. So once again, you look at the bones. There's the middle phalanx on the dorsum, and this is the proximal phalanx. And there's my central slip. No, sorry, let's go back there. There we go. So there's my central slip. Now I'm going to take the yellow away. There's my central slip, but when it moves, you can see it more easily. See how the central slip is moving my middle phalanx? So if you want to see if your central slip is attached with a boutonniere or not, just look with the ultrasound probe. It'll help you. With a booster and without a booster. On the left, no booster. On the right, with a booster. Now you're looking at the PIP joint, and there's the central slip again. See how nicely you can see it? On this side, it's harder to see because there's no gel between the probe and the skin. And so it's very, very helpful to have these probes with boosters on them. But you can make your own booster. And if you have a booster, you can go right around the finger. You see the space there? This is all gel over the finger. And he's going around the finger. He's looking at the collateral ligaments on the side. He's going around to the top of the PIP joint. And he's going around to the other side. And this is all Dr. Vincent Martinez from France. Very, very clever man. And this is also from him. This is a schwannoma of the median nerve. And this is what it looks like in cross section. So there's the median nerve. Now, as he moves the probe up and down, there's the schwannoma. There's the median nerve without the schwannoma. Now we're going to look at it longitudinally. There's the schwannoma. There's the nerve. Right there is the nerve. And there's the schwannoma. Now there's with a booster, you see it even better. So remember I said the median nerve has black lines in it. So this is the median nerve over here. This is the schwannoma over here. And these are the tendons underneath. They don't have the black lines that the nerve has. And that's how to tell if you have a nerve or a tendon. See, there's the black lines on the other side. And that's what it looks like with an MRI. And that's what it looks like when he took it out. So get your probe at the top of the mountain. The view is better from the top of the mountain. And if you're looking at flexor tendons, get the patient to hold all their fingers together because it will keep the mountain from slipping in between the fingers. So that's a tip when you're looking at the flexor side of fingers or the extensor side of fingers. So this has almost no gel between the probe and the skin. This has a lot of gel between the probe and the skin. Right. So I'm just going to show you this little video from my friend, Dr. John Fowler from the United States in Pittsburgh, because it talks about how to hold the probe.
So I've got a pretty good image right here. Now, if I lean the transducer back, I would kind of call that tilt. You see how things kind of start to disappear a little?
Okay, so this is what's called tilting. So you probe your you take your probe and tilt back and forward. When you tilt back and forward, this is the median nerve right here. The median nerve stays into view, but the tendons kind of disappear if you're not at 90 degrees to them. So when you tilt backwards, the median nerve stays there, the tendons disappear.
Like when I'm straight up and down, perpendicular to the tissues, everything.
See, here's the tendons, they're white, they're solid. There's the nerve, it's got the black spaces in between. So when you're perpendicular, you see the tendons and the nerve. When you tilt back, you only see the nerve.
I can see everything. But if I tilt backwards, I start to lose stuff.
So you can still see
I can see everything.
you can still see the nerve when you tilt back, but you lose the tendons.
Tissues look different based on the angle being puts them. And so you want to be always perpendicular to what you're looking at. And I can tilt the other way too, and things kind of go away. Now what's happening at the side of the screen over there, see that kind of wavy stuff?
That's artifact.
That's because I don't have contact with my body, or I don't have a.
And he doesn't have contact with his body because he doesn't have a mountain of gel. Him and a lot of people who use this have this very thin layer of gel and they keep complaining about artifacts. The answer is put more gel.
The other kind of tip is if you can't see well, put more gel on. That's kind of, you always need more gel. All right, so that is tilt. You can also rotate. So we're in the short axis right here, and I've got the nerve. So that's my median nerve, right at the middle of the screen right there.
That's the median nerve.
If I keep that centered and I just turn this 90 degrees, keep it centered, I am now looking at all these structures kind of in the long axis.
So there's the nerve there.
But I would try to convince you that's my nerve.
That's the nerve. That's the tendon. You see how they look different?
These are the flexor tendons just below. And if I make this a little more deep, you actually be able to see the carpal bones.
There's the
So
nerve
this is
tendons.
the lunate right there, lunate distal radius right there. Actually, you can see pronator quadratus pretty clear.
That's pronator quadratus, distal radius, and lunate. And you'll figure out your own carpal bones as you look.
So if you have a distal radius plate, you can see that pretty nicely too. And then I'll kind of turn back into the short axis again. So you can see what I'm doing. I think it's really important to support the transducer by something. I usually hold it in my fingers here, and I rest my small finger on there, and that gives it more stability.
That's a very important point. Don't just hold the probe with one hand because you're going to slide right off the patient. Always support your probe with your little finger so that you're not sliding off the patient.
Things get kind of slippery and you start moving all over the place. So I see a lot of people, they hold the transducer like this, and it's really hard to not let go. This kind of like grounds you to the hand when you do that. So I guess one of the first things you have to kind of decide is what type of machine you want, what type of probe you want. And I kind of hold these 3 different transducers which are attached to the machine. And you can see there's like numbers on here.
Okay, so here's the short version. The higher the number, the better it is. The higher the number, the more expensive it is. So my Clarius that fits on my iPhone is 20 megahertz. It's a very high number. It's better than my Butterfly. That's why the Clarius right now is the best one for your iPhone, because it's got 20 megahertz. And the higher the number, the better you can see. Low numbers are to look inside the abdomen in a deep cavity. You're not going to do that if you're a hand therapist. So you don't want something that has low megahertz because it's not going to get you what you want. So that's how you decide which probe you want. You want the one with the highest megahertz. But if you use a mountain of gel, you can take a cheap probe and make it better. So that's an important thing to remember. So that's basically what he says there. And
so like this is the depth button right here, and I can kind of make this deeper or less deep. And basically it's kind of like x-rays. You want to have whatever you're looking at to kind of be the center of the x-rays. You don't get parallax. There's no parallax in ultrasound. But if you're doing carpal tunnel, you want to be kind of less deep. So I'll kind of put this on and just take a look at this one so you can see what I'm talking about. So if I put this transducer kind of right here across my wrist, we can get a picture right there. I have the needle thing, so I'll turn it on. We're gonna get a picture now. I would say I'm probably a little bit too deep right now. So if I come over here to depth, I'll make this a little less deep. So this is as shallow as it goes. So you have that structure right in the middle of your screen. The next thing you want to adjust is your gain. So gain is how much energy that it's shooting to the tissues. So if I turn the gain way up, you see everything gets like really bright right there. Or if I turn the gain way down, everything gets kind of dark. You kind of want a happy medium.
so there's really only 2 measurements that count. Gain, which is how black and white it is. In the middle is what you want. And depth, how deep you're looking. And you can either go like 1 centimeter, 2 centimeters, 3 centimeters. You just do it so you can see what you're trying to find. So ultrasound exams, I think all therapists should get into it. In the Wide Awake Hand Surgery book, there's 2 whole chapters on ultrasound. And, you know, there's 8 hours of video on how to use ultrasound, how to use the probe. So if you have the 2nd edition of Wide Awake Hand Surgery, just go in there and there's 8 hours of ultrasound education. You don't have to take expensive courses on how to do ultrasound. You can teach yourself. That's my 2 dogs. Okay, so I'm going to stop sharing. And I think it's Nurìa is now going to educate us.
Yes, thank you, Mr. Lalonde. Now it's the Nurìa turn.
Thank you.
Yeah, we
Just-
can see.
And can you see the red point?
Yes, we can see the red point.
Thank you. Okay, so first of all, I wanted to thank you, Mario and Susanna, for the invitation. It's a great pleasure always to be here. And it was a great pleasure also to, again, share a session with the Dr. Donna Lalonde. First of all, I would like to say that I'm so sorry, I'm gonna speak in English. It's not my native language. So thank you if you take patience with me if I make some mistakes, maybe some funny mistakes. So if this works, I'm gonna start. First of all, I would just like to say that I'm a hand therapist. I live in Barcelona and I work in Barcelona, Spain. And here in our country, lots of hand therapists are physiotherapists as me. And now having a ultrasound in the hand center, it's like a very trending thing. So everybody, almost all the physios are having some ultrasounds on the clinic. And this has been also an increasing topic because of climbing injuries, because now there is an increasing number of people climbing indoors in climbing gyms. So hand therapy centers are full of these patients. And here in our country, we use a lot of ultrasound to treat this kind of injuries. I would just like to talk to you about only 5 key messages, which I think are the most important if we talk about the role of ultrasound in hand therapy. And with that, I'm gonna tell you a kind of a love and hate story, and you will see why I'm talking about that. First of all, I think that if we, as hand therapists, we use ultrasound, we can innate accuracy in our treatment. So we can use ultrasound as a guidance for therapeutic procedures, so for therapeutic choices. And I think that's the thing which I love the most about having a ultrasound with me when I treat my patients. And I will show you an example with a clinical case. Once I saw this patient, it was a girl, she hit her finger, and in the emergency department, she had the typical diagnosis of capsulitis. And yeah, she came to me in the clinic and I explored her, but she had that much pain that almost all the tests were sensible, all the tests were positive. She had pain when exploring the volar plate, she had pain when exploring the collateral ligament, so she had pain, and for me it was just impossible to decide which had to be the treatment for the splint, the orthosis. I had to choose. So here I decided to take my ultrasound and make sure that I was right. And yeah, when I was trying to explore the volar plate in the volar side of the PIP joint, this is what I saw. It was like fluid there and there. And when I was taking a look to the collateral ligaments, it was just more like a normal image. But then let's take a look on this video, because then if I have this, I cannot use the video, I think. No, it's not working, the video, if I have the red light. So maybe just... yeah, like this. So I started to go around the PIP joint, and finally I could see something. It was a piece of bone. I don't know if you can see this round piece of bone, which finally confirmed me that there was a true injury in the polar plate. So I had to choose the right orthosis during 3 to 6 weeks. Now, you know what we have to do with polar plate injuries, but this was the key to understand that finger, which was swollen and painful. And now I could understand that it was just a polar plate injury. I used the first splint during 3 to 6 weeks, and then I gained the final range of motion of this extension PAP joint, which at least was stiff after the orthosis. So that could lead me to find the right treatment with this case. A second thing I would just like to say to you, if you have a ultrasound, just switch on this ultrasound. And this is kind of a thing which I love and I hate at the same time, because having a ultrasound, it's a way to facilitate patients' engagement. They love ultrasound. And yeah, sometimes I don't like it because I have messages like this: "Hey, Nurìa, do you have any appointment for me? I need a ultrasound." So they don't need a hand therapist anymore, but a ultrasound. So this kind of a thing that I sometimes like, and sometimes I don't like that much. But it's true. I have a friend, a very good friend, a hand therapist from Spain, from Tarragona, who always says, if you have a ultrasound, you have to switch on the ultrasound the whole time, because patients really love ultrasounds. And that's true. If you have a ultrasound in the clinic, that works and patients come. But I would just like to say to you some things which are, good to have a ultrasound in the clinic. Another case, if we have a ulnar-sided wrist pain with one patient, we could hesitate if it's a TFCC pain, if it's a tenosynovitis of the extensor carpi ulnaris, and you know, there are so many causes of structures which could lead to ulnar-sided wrist pain. So sometimes, again, tests are a lot sensible, but not that specific in some cases. So I can go through ultrasound and compare if we have a big around the extensor carpi ulnaris. Maybe it's not the TFCC which is hurting, and I will have to adapt this treatment on the real structure I have. But wait, it's important to switch on the ultrasound, but remember that we don't use it for everything. So there are some structures that we can see very good, see that good. And of course, we don't have to speculate. We don't have to assume things that we don't know for certain, because sometimes with the ultrasound, we try to make some affirmations to assume things which are not that true. For example, if we suspect from a scaphoid ligament injury and I say, okay, I have a ultrasound, so let's take a look on that, because maybe I can measure the distance between the lunate and the scaphoid. But wait, which distance? We have other ways to know better what is that, and sometimes we need to refer these patients. We have not the power because we have the ultrasound. So if we wanna see the sign of a teratomas, maybe the ultrasound is not the best solution, and we have other option, X-ray option, with our colleagues, the surgeons, which work better. So we have to ask ourselves if the ultrasound is the right tool to use in every case. And yeah, this is a third point. I like to use the ultrasound, as also Dr. Donna Lalonde said. I like to use ultrasounds for patient education. I love this because this sometimes improves people understanding their condition, their problem. And here you will see another example. I have a patient now, so it's not the end of this case. I have a patient. She had a flexor tendon problem 2 years ago. Then she had the pulley reconstruction, but after the pulley reconstruction in a second surgery, she had a very serious problem with an infection. So now the proximal tendon gliding of the finger, it's pretty difficult for her, and it's kind of a frustrating thing. And so I decided to take the ultrasound with her and show her how a tendon, a normal one with a healthy finger, normally glides. We are in the in the MCP joint in a longitudinal axis. And then I asked her to move the finger, as she could see how the tendon glides proximally and distally, and proximally and distally. And then I said to her, let's see how your infected finger is working. And then she could see that in the same place, the MCP joint, the tendon with the active range of motion with her was not gliding at all. So at this point with her, I have a stiff finger, which is not moving. It's not moving in the passive way and not in the active. And I told her, maybe now we have to work more in the passive range of motion of your finger to work to decrease the work of flexion, and then we will also increase this movement or this gliding of the tendon. And that's a way to avoid patient's frustration, because when I ask her the active movement, the exercise, which she needs to do every day, she feels kind of frustrated. But I say to her, keep moving, keep trying. Yeah. Fourth point. This is the point I hate the most because, yeah, we are hand therapists here in Spain. We love ultrasound, but sometimes we forget about physical examination. So I love physical examination, and I think that this came first, and we need physical examination before using the ultrasound. And I'm going to explain you a case that I had some years ago. It was a climber. It was not my patient, so he had been 2 months before to another physiotherapist, and because he was climbing and there was a pop sound, and they suspected from an A4 polyrupture. And I imagine that the physiotherapist was who was exploring with the ultrasound. This is a normal A4 pulley, so we can see in the second phalange the flexor tendon, which moves close to the tendon, and in a rupture A4 we see in the same second phalange how with the active flexion of the finger, the tendon tends to separate from the second phalange. So when this patient came to me 2 months after having this injury and seeing the physiotherapists, the other physiotherapist, I avoided to take a look on the ultrasound, and I just made the physical examination on him. So I asked him for a full fist with the strength to pull on that. I asked him for a straight fist, and there was something weird in his finger, impossible to pull through my resistance. Then I asked the hook. It was working. Moving on. Here I was looking for the other finger, flexor superficialis tendon, also the fifth finger, as he could take a look, and then the third finger, the flexor superficialis of the third finger was not working at all. So I didn't need a ultrasound to know that the problem was not the pulley, the A4 pulley, which maybe was also injured, but in fact, the key was that he had an avulsion of the flexor digitorum superficialis. So there, the physical examination had missed, and there was no more solution for that. So I referred him, but now he just climbed with a tendon less. So that's important. We have to remember that we are hand therapists. We can start to use ultrasound, but we cannot forget about physical examination. And at least the last thing I wanted to say to you today is that, yeah, start to use the ultrasound, because it is a great way to learn and study. I agree with the Dr. Donna Lalonde. I never had a course about ultrasound, and I use it a lot, and I have fun. In fact, if you know, last year I finished my PhD about lumbrical flexor digitorum profundus muscle injuries. And one thing is that normally, as when I had one patient with a lumbrical injury, I always suspected that the injury actually was in the flexor digitorum profundus, because we had always this image of synovitis around the fourth flexor digitorum profundus. So that was a key point to start discovering a little bit more about that. I met some fantastic surgeon colleagues, and we made great research work in the biomechanics laboratory, which finally was published. And that was because I started working with this kind of patients in the clinic. I was curious, I was switching on my ultrasound, and I wanted to learn more and more. So I don't wanna last more than these minutes I took, but remember, using a ultrasound enhances accuracy, so it's a good point. Switch on the machine, but don't speculate. You can use ultrasound for patient education. It cannot replace physical examination. And of course, use it to study, to learn, and to have fun. Thank you.
Thank you.
Very
Nuria. We have some chat questions. I have one for you. Serena asks, could you suggest some ultrasound models, and how much does it cost?
Yeah, so the Clarius ultrasound that I have, the 20 megahertz one, is the more expensive one. And I think that I'm not sure how much it costs, because it depends on if you add the internet part or not. But it was around $3,000 or $4,000, as I recall. So it's not cheap. The butterfly was cheaper. The butterfly is the wired one, but it's a lower number, so it's not quite as good, but it's still better if you put it underwater. The butterfly was $2,000. And if you buy a bigger machine, you can, the big machine that you buy for your clinic, if you get a really good one, they can be $80,000 to $100,000. So I don't know, how much was yours, Nurìa? How much did you pay in American dollars?
Yeah, so I bought one last year and I compared different prices here in Europe or in Spain. I don't know if it's like the same price. The Clarius was 9,000 euros.
Okay.
Yeah, and the Viscan, the one that I have now, it's quite cheaper, so it's 5,000 euros, and the image is not that different. So I could try both, and I could compare, and it's not that different.
Right. And especially with a mountain of gel, you can take a cheaper ultrasound machine and make it look better. Maybe the reason that you paid more for the Clarius is because I bought it when it first came out. I bought one of the first Clarius machines they made because I heard about it, and anyway, and I'm an ultrasound nut. I'm a fanatic. I love looking at everything with ultrasound.
We cannot hear you, Mario.
Oh, sorry. We have other questions from the chat. For Dr. Lalonde, in some countries, such as here in Canada, there are clear restrictions and OTs and PTs providing diagnostic services, since the use of ultrasound can sometimes be perceived as failing into that category. How do therapists working with you approach these regulatory challenges? And I completely agree this kind of question, and I previously tell you, Mr. Lalonde.
Yeah, that's a very good question, Pedro. And this is a problem all over the world. And the problem is that some people will come to you and say, you're not allowed to use the ultrasound because you're a hand therapist. And even in Canada for surgeons, in some provinces, for example, in Ontario, in Canada, the radiologists are stopping the surgeons from using their own little X-ray machines in the clinic. But look, these are things that are mostly about money and power. But here is my advice to you about how to get whichever organization is stopping you from using the ultrasound. Here's what I would suggest. The first thing is don't go to a committee to get them to change the rules. Find out who is the person in charge who is stopping you from doing something. And then what you do is you go with the president of the Hand Therapy Society of your country, and you make an appointment to see the person who is in charge. It's better if you can do it in person. If you can't do it in person, do it on Zoom, but make an appointment to see that person. So what you do is find out who is making the decisions that are stopping you. Make an appointment to see that person and call them up and say, I would like to make an appointment to see you for your opinion. Everybody loves to give their opinion. Doesn't matter if they're a politician or somebody who's very powerful, they love to give their opinion. So you say, I would like to make a 15-minute appointment to get your opinion. You go there very well prepared. You have a PowerPoint presentation that's 5 minutes long, and always make it about the patient. Don't make it about your organization. Don't make it about money. Don't make it about you're restricting me and it's not fair. You make it about why this is good for the patient. This is why I should be able to use ultrasound on my patients, because these are the benefits. And you show them exactly the same kind of slides that Nurìa and I just showed you. Say, if I can use ultrasound, I can help my patients in this way, in this way, in this way, and in this way. If somebody else does the ultrasound, that doesn't help my patient. And then you stop at 5 minutes. You still have 10 minutes left. And then you say, we would like your opinion on what you think of this and what kind of hurdles and problems that you have from letting me do this. And then just listen. Just shut up and listen. Let that person vent, and you will hear what all the problems are from their point of view. Some of them you might be able to solve, some of them you might not, but don't interrupt them. People love to hear themselves talk. Let them vent and just listen and listen and listen. At the end of listening to them for 10 minutes, and don't come back and counteract and start arguing with them. No. What you do is you say, thank you so much for your opinion. Now that I understand better the problems from your point of view, I'm going to go home and think about how we might solve some of the problems and get over the hurdles. And respectfully, I might ask you if maybe you might come up with some suggestions for us after we finish our meeting. And maybe you might be able to help us find a way to get over these hurdles and problems that you say. If there are 3 or 4 people who are making the decision that are stopping you from doing things, don't go see them as a group. Never go to a committee when you want to make a change. Go to them one at a time and get their opinion and find out who in the committee is on your side, who is against you, and find out why they are against you, and try to figure out a way to help them change their mind. That's how you get changes done in any government, in any society, in any group, in an effective way. And that's what I would suggest you do in your countries. You get, and it's better if you get somebody in your organization. You know, if you go to them as Nuria Carnicero, as just one person, they go, well, who's that? Who's Nurìa? But if you go, I'm the president of the Hand Therapy Society for Spain, and I would like your opinion, then they go, oh, okay, this is like more official. And so, and I would do the same thing. I would go, you know, my name is Don Lalonde, I'm a plastic surgeon, who cares? But if I go to them and I say, I'm the president of the Canadian Society for Surgery of the Hand, and I would love to make an appointment with you for 15 minutes to get your opinion. All of a sudden, it's like, oh, okay, maybe I should pay attention here. Maybe I should give this person my opinion. So these are some ways that you can make changes. But if you make it about the patient and all of the advantages for the patient, then they are obliged to listen to you. They don't have to help you, but they have to help patients.
Yeah, I would just love to add something, because I think the same. We have to think for hand therapy that ultrasound is a tool. It's a tool to better understand. Maybe we are not the right people to make diagnosis, but it's just a tool. You see the tendon, which doesn't glide in a good way, you want to improve that. You make some exercises and you look again. This is not a diagnosis of an illness, but it's just a tool to see what's happening there. So we are not worsening the work of anyone, but just working for the patient.
Yeah, I think that's a really good point, Nurìa, because if they think you're going to use it as like a radiologist to make a diagnosis, they're going to get angry. But if you're telling them, no, I need this to help my patient get better, then that's a whole different kettle of fish. So I think, Nurìa, that you did a much better answer than I did.
It's nice. I asked Tom Latre if he's still joining us. How do you legitimate as a teacher in this field? Because you are making first courses in Belgium about it. If you can share with us your point of view.
Tom, you're there. Make yourself visible. Are you allowing him to make himself visible? Yeah.
Now you see me?
Yeah.
Yes.
There you are, Tom. We can see you.
First, Nurìa and Don Lalonde, it was a great meeting and session with a presentation. I liked it very much. So my point of view about this subject or matter, I just started some years ago with ultrasound. Didn't know why, but I just started. I didn't even know if I could do this in Belgium or not. And I just started with one patient, followed some courses, and then step by step. And I don't have any surgeons who are against it. They are all with me, and they trust some of my ultrasound images. And if I'm not very sure, I'm always saying to the surgeons, please double check this with a doctor in your hospital, and that's a fair thing to do. So I have nothing to say about that. Just start and keep it simple and basic. Earn the trust of your surgeons and doctors, and then advance step by step.
Good advice.
Okay, thank you, Tom. Are there other questions? Nothing in the chat?
Yeah, I see I've got an L15, good to start and learn. That was Tom. Yeah, and
Yes.
I'm sure that underwater, an L15 almost looks like an L20. Or with a thick layer of gel.
I choose the L15 because it has a broad scan area. The
Right.
L20 is much smaller. So for the beginning to learn ultrasound, you can see more with a broad scanner than a small scanner. So on one finger, it's almost entire finger flat of the hand. You can see more than with a small transducer. However, with a small transducer like the L20 or the hockey sticks from a big machine, it's a higher megahertz, so we see more in detail. If you want to see small nerves in the finger, with this, it's difficult. So you have to choose. And now I'm a bit more advanced in ultrasound. I'm thinking about to buy an L20 to see more detail. So
What's a super advice?
it's a big investment.
Yeah,
And
it is.
why should you buy a big machine if you are not sure about it? It's perhaps better to start easy on with a cheaper device, and then you can go further and further with other devices, higher quality and higher prices. But in Belgium, I don't know, in Spain, can you charge your patients extra for this or not?
No.
No.
So
And
it's
also
not
in
allowed
Belgium.
for us to make diagnosis with ultrasound. So it's a tool we can use, but it's not something that we can sell as a service.
Right. And in the United States, doctors can charge patients for ultrasound, but in Canada, we cannot. You know, one thing I would tell you too is if you get an ultrasound and an ultrasound probe, don't drop it. If it falls, it's very expensive. So, because you can break it. It breaks inside. So treat it like a very special thing. Don't just wave it around and give it to kids to play with. And, you know, this is something that you treat like something
Like a
very
baby.
precious, like a baby. Exactly. Yeah.
A great advice I would say to you that, or here in Spain, it's easy to have a demo with the company which wants to the ultrasound, the proof. So first I tried Clarius, then I tried Vscan from General Electrics, then I tried one other from Philips, and at the end I decided which one was the best for me, for the quality, the investment. So if you have the time and you have the opportunity, it's great to have demo of the device before buying it.
Yeah. Good advice.
Okay, others? Or we will close this session. I don't see nothing. Okay, are you sure? Okay. First of all, a heartfelt thank you to our distinguished speakers, Mr. Lalonde and Nuria Carnicero, for generously sharing their expertise, experience, and passion with us this evening. Your contributions have truly enriched us and our understanding and inspired our practice. Thank you so much to stay with us and join us this evening.
Thanks
Thank
very
you.
much for having us. Have a great evening. Goodbye.
Bye to all.
Goodbye.
Bye.